In this case, we had a 72-year-old male with severe comorbidities needing correction for an 83 mm juxtarenal aneurysm having a quite narrow lumen at the origin of the visceral vessels. We decided to treat him using the off-the-shelf preloaded e-nside endograft from aortic, taking advantage just of femoral accesses for bridging components deployment. Procedure begins advancing the endograft over a super stiff guide wire, in this case through a 24 French introducer sheet. The endograft is moved up to the intended deployment position and angio is shot and the fusion marker position adjusted according to the overlay reference. The endograft is then deployed, mostly relying on the distance between the renal arteries branches outlet and the target vessel fusion markers. Then the proximal end of the graft is set free, and from a contralateral femoral axis, a 12 French steerable sheet is advanced until the cranial edge of the endograft and gently bended. Then one vessel at a time, a femoral through and through is established, capturing the preloaded guide wire with a snare. Maintaining the steerable sheet proximal position, a smaller sheet is advanced over the through and through across the target inner branch. The target vessel is cannulated and the guide wire exchanged for a more supportive one. At this point, the bridging component is advanced directly from the proximal 12 French steerable sheet. Once the covered stent is in position, the through and through is removed and the bridging stent inflated. In this case, you see these operations in the superior mesenteric artery, which was our first target visceral vessel to be revascularized for this case. Here we have the bridging component, advancement, and deployment. In this case, a balloon expandable bridging component. This was a VBX. A control DSA is performed and the procedure is repeated for each target visceral vessel. We have then the right renal artery cannulation. Over the through and through, we advance a smaller introducer sheet and a catheter to cannulate the target visceral vessel with an hydrophilic guide wire. In this case, catheter is advanced, guide wire exchange for a more supportive one once the position of the target of the catheter is checked inside the target visceral vessel, and the bridging component advanced directly from the 12 French steerable sheet at the proximal edge of the aortic endograft. Once the covered stent is in position, the through and through is removed and the covered stent can be deployed. In this case, we reinforced the bridging component with a BMS because of a kink at the origin of the target visceral vessel. And a DSA control was definitely good. So again, the procedure was repeated for the left renal artery. Target vessel was cannulated. See here the hydrophilic guide wire advancement into the target visceral vessel. Catheter again advanced, guide wire exchanged with a more supportive one. Bridging component advanced from above, and once in position, through and through is removed and bridging stent deployed, connecting the target visceral vessel with the graft's main body. And the SA control was good. Final visceral vessel revascularized was the celiac trunk, again using the same technique. We cannulated the splenic artery in the first time, then decided to position our guide wire into the hepatic artery, as we always do. Catheter position is checked. Supportive guide wire is advanced. And bridging component positioned and inflated. Another VBX in this case. And here we have the inflation of the bridging component. And angiographic control, of course. So once each target vessel has been connected with the main endograft, the steerable sheet can be removed, as well as the aortic graft delivery system, reperfusing the lower limbs. After completing the procedure with the iliac landing distally, the final angiographic control shows aneurysm exclusion with effective target vessel revascularization, and the result is confirmed with the contrast CT scan performed a few days after the procedure. Thanks for your attention.